Good afternoon. So we're moving on now to our next panel, which is a group of experts in various subspecialties, and they're each going to take a little bit of time to discuss what they do and why you might come see them. And without further ado, we're going to start off with Dr. Kim Risma in our Allergy and Immunology department. With that, I will turn it over to her.
So the first question that I have for you is, that I imagine you might have for me is, does my child need an immunologist or an allergist? So I put up here an acronym for CHARGE, and you can see that there's nothing on there that suggests that you would need an allergist or an immunologist. So why am I here? And I would suggest that of the different defects that we see, that there are lots of different abnormalities that may be related to the immune system in terms of causing recurrent infections or being related to growth. However, what I would propose today is that really CHARGE should be iCHARGE because there is a substantial immunophenotype in CHARGE syndrome, and that's what we'll talk about today. So moving on, what are the CHARGE immunotypes or immunophenotypes? Phenotype just means like an expression of the disease. So one you would recognize immediately, and that is recurrent infections. And that doesn't really need any kind of explanation because if your child has recurrent infections, you know that. They might be ear infections, they might be urinary tract infections. The second smaller bubble, and I made it smaller intentionally because I think it's less common, is lymphopenia. And the third smallest is something called SCID. And most of us would then say, what is lymphopenia and what is SCID? And so I'm going to talk about that. So first we have to talk about the immune system, which is generated in the bone marrow. So the white blood cells are made up of three main types of interest to me. The first one is neutrophils. It fights bacterial infections, and monocytes, which does that as well, and also is involved in a more sophisticated immune response, which calls in lymphocytes. And so we're going to spend our time talking about lymphocytes, and there's three different kinds. They are called B cells, T cells, and natural killer cells. And they are involved in something called immunity. And immunity means that we have memory. Our immune system remembers something and keeps us from having recurrent infections. And so the cells that are involved in that are B cells, T cells, and natural killer cells. And for CHARGE syndrome, we focus on T cells. So if there's reduced T cells, as we find sometimes in CHARGE syndrome, we call that lymphopenia. Lympho just means white blood cells. Penia means not enough. And so if there's not enough, as in 0, we call that severe combined immunodeficiency, or SCID. And that's the most rare of all of the immunophenotypes that we can see in CHARGE syndrome. And that means that there's no T cells whatsoever. So you might ask, why is my child at risk for low T cells? The reason for that is that T cells are generated, although they're born in the precursors to T cells are born in the bone marrow, they're actually educated in the thymus. And so the thymus is an organ that sits in front of the heart, and the T cells I call them T cell wannabes. The progenitor T cells come out of the bone marrow, and in order to become T cells, they have to go and become educated in the thymus, and that is the little T on the top of the heart there. Once they leave the thymus, they go out into the periphery, into the lymph nodes, where they're naive T cells, and you can see I have a little graduation cap on them, and that just means that they're ready to fight infections and that they are mature. And their job is really to fight viruses and respond to vaccines. And so you've heard a lot of talk about vaccines in the lay literature these days for example, for coronavirus. And so naive T cells are necessary to fight viruses and respond to vaccines. So if you don't have a thymus, as sometimes occurs in CHARGE syndrome, if there's a defect, if it's absent at birth, or if there's decreased function over time, then you would have reduced T cells and reduced ability to fight viruses or respond to vaccines. I'm sorry, I'm having trouble with my slides. So if you have an absent thymus at birth, this is quite rare, and I wrote in here that then you would have SCID. So absent T cells at birth means, absent thymus at birth means absent T cells, and as I said, that is a rare disorder. What is less rare is when we see that there are decreased function of T cells and decreased number of T cells over time. SCID itself, every child is screened for at birth in their newborn screen, and so everybody actually has an immune evaluation at birth. You may not know it, but every state is now live for newborn screening for SCID, and patients with CHARGE syndrome who have 0 T cells are picked up this way. However, the decreased function of lymphocytes over time, of T cells over time, that's really unknown how often that happens because a lot of children never really have an immune evaluation. If you have either recurrent infections or your pediatrician or inpatient team notices that you have low numbers of lymphocytes, they may ask for a referral to an allergist or an immunologist, and that's when I would get involved. And what can you expect as a parent? So my approach to a visit is the following. First, we review the infection history. We ask about hospitalization. So in other words, how serious are those infections? Were they happening in the currents of daycare, or was your child completely sequestered at home due to a pandemic, for example? And I review the blood counts. I might order a more sophisticated immune evaluation, which is also blood testing, and then make some recommendations. For SCID, these patients have to be referred for a new thymus, and so that's a thymic transplant. And as I said, that's quite rare and diagnosed at infancy. For those who have lymphopenia, those the lower number of T cells, we can either watch and wait, which is quite typical. We might order additional vaccines to try and boost immunity. We might put a patient on antibiotic prophylaxis, and less commonly put patients on immune globulin replacement. That's called IVIG. So I wanted to end with that. That was my summary of why you might need an immunologist, but I am also an allergist, and there's just a slight difference there, and then I think about allergies as well. And so you might ask, does my child need an allergy evaluation? And I would suggest that some kids may have allergies, although in my practice I haven't seen a lot of patients with CHARGE with true allergies to like pollens and dogs and things. But what I do notice is that patients often have antibiotic allergies, and that is worth addressing in our patients with CHARGE syndrome, because if they have, for example, a penicillin allergy, they may have avoidance of penicillin, and that is a problem. They have to go to antibiotics that are more expensive and have more side effects. So I do just want to tell you that, give a shout out that we do have amoxicillin allergy testing available every day at our institution. And I do think this should be part of our patients who have CHARGE should always be referred to the penicillin allergy testing service if there is a penicillin allergy identified, because then those patients, we know that 95% of children who think that they are allergic to amoxicillin, when you give them amoxicillin again, they don't have an amoxicillin allergy. So we put that back right in their repertoire. So that's helpful. And then that is really just an oral challenge. And this is Trisha Wendling from our practice who runs this every day. And that is just a little commercial saying where you can find the penicillin allergy testing service. So that actually is super common. 10% of all patients in our community have penicillin allergy, whereas far less have lymphopenia or SCID. So I'm done.
Excellent. Well, thank you, Dr. Risma.
You're welcome.
So we were going to save time for questions at the end, and now we will move on to Dr. Malon Rutter, who is one of our endocrinologists.
So I'm Malon Rutter. I'm a pediatric endocrinologist at Cincinnati Children's, and I'm going to talk today just briefly on why and when we would need to see an endocrinologist if we have CHARGE syndrome. I'd like to start off with 2 poll questions, and this is the first. This question is for families who have a person with CHARGE syndrome, and it's really just drilling a little deeper in terms of whether you see an endocrine specialist. So the question is, do you see an endocrine specialist? The first answer is no. Second answer is once or twice, but really no established care. The third answer is regularly or established care. And the fourth answer is, well, I'm really not even sure what an endocrinologist is. So we'll just pause for a few minutes, or a few seconds.
That's nice.
Do I just advance? So it looks like of this group, quite a number of you regularly see an endocrinologist, and about a third of you might have seen an endocrinologist once or twice or not at all. And nobody doesn't know what an endocrinologist is. So here's a second question, and this is really for everyone if there are any health professionals or others in the audience as well. What is the most frequent endocrine issue in charge? Is it low growth hormone? Is it low puberty or sex hormones? Is it low thyroid hormone? Or I'm not really sure. Perhaps that's why you're here today.
Catherine, you're supposed to sing in the middle while we're waiting for
Is
the
that what's
polls.
supposed to
That's
happen?
what the moderator's supposed to do, yeah.
So we'll
Just
just
given that memo.
My God.
All right.
The Jeopardy.
Yes.
And this is not in my control, so we will
It's
just
not. No,
we'll
it's
just
really-
be
that's going
patient
on.
and
It's
wait for the answers to
It's
come
hard to
through.
pause. Yep.
I couldn't. I found it impossible.
There we go.
There
Thank
we
you,
go.
guys.
So it looks like 2/3 of you think that the most frequent endocrine issue is low growth hormone. About 9 or 10% think it might be low sex or puberty hormones, and then about a third of you are not sure. So I'm glad to see those answers because now hopefully I can fill in some of the gaps here. So today, in just the next few minutes, I'm going to talk briefly about, firstly, what is an endocrinologist? And really, I think we've already given that answer. An endocrinologist is a doctor or specialist who treats or cares for people who have conditions involving the endocrine system. And then I will talk briefly, just as an overview of what the endocrine system is, and ask the question, why and when should someone with charge see an endocrinologist? In other words, what are the endocrine issues in charge and what can we do about them? And this is Adam. This is one of my patients who has charge syndrome and I think has taught me most of or much of what I know about charge syndrome. So you may see him popping up here and there in my talk. So firstly, what is the endocrine system? It's a system in the body that comprises of glands that make hormones, which are chemical messages, that travel to different parts of the body and bring about many important functions. And you can see those listed there. And I really just want to say that most of these, if not all, are pertinent for people who have charge syndrome. The endocrine system really starts with the brain, and in the brain there is a master controlling gland called the pituitary gland that makes several controlling hormones that speak to other glands in the body. So for example, there are the hormones that control the puberty system, and these also control genital development, especially in boys before birth. There's also growth hormone that comes from the pituitary that's very important for helping people to grow normally. And then there are other hormones too. There are hormones that control the thyroid gland and hormones that control the adrenal gland. So you've already seen this slide, and I think all of you are probably familiar with this acronym. But I really just wanted to highlight that 2 out of the 6 of these letters actually pertain to the main endocrine issues that people with charge may experience. And those would include slow growth or delayed puberty, or difference in how the genitals develop, particularly in boys. So coming back to one of those poll questions, and if you remember, most of you, or at least 2/3 of you, thought that low growth hormone was the most common endocrine hormone deficiency. So in fact, many, if not most people who have charge syndrome actually have a deficiency of the sex hormones and the system that controls both puberty as well as genital development. And then those who answered growth hormone, you're not entirely wrong. In fact, most, about 3/4 of people with charge syndrome may have short stature. However, only a minority of those would typically have growth hormone deficiency, contrary to popular belief. And then a few might have either an issue with structural abnormality of the pituitary gland or a deficiency of the hormones controlling the thyroid or the adrenal gland. So where are we when it comes to endocrine care? And this really speaks to that first poll question that I was asking. And it sounds actually like many of you see an endocrinologist pretty regularly. But the question really is, have we never seen an endocrinologist? Or perhaps we've seen an endocrinologist once or twice when we've really had to, but never really established care. And really, endocrinology may feature fairly low on the very large laundry list of all the health issues that really need to take priority. And then it looks like many of you are actually quite proactive with your care, where you have an established endocrinologist or may see an endocrinologist on a regular basis. So firstly, I'm going to talk briefly about slow growth in charge. This is the height growth chart of one of my patients. And you can see this is over the first 2 years of life. He really illustrates what may be typical in children who have charge syndrome. So at birth, you can see right at the very left-hand side, often birth size may be normal or in the low normal range. During infancy, there may be poor growth. So you can see that by 2 months and 4 months, he's starting to fall off the growth chart. And the dots there, which pertain to his height, are below the low end of the growth chart. In childhood, often children may remain short, but may actually grow with a normal rate. And then during adolescence, it really depends on what's happening in terms of puberty or treatment for puberty. So what are the causes of poor growth in charge, if only the minority have growth hormone deficiency? So you can see here, many of them are non-endocrine. They may be related to feeding or aspiration issues or nutrition or other health issues such as heart problems, surgeries, or infections. And then in terms of endocrine causes, about 10 to 15% may have growth hormone deficiency, and then later on, puberty may factor in as well. So what can we do about it? Well, first of all, we need to optimize nutrition and health and treat the underlying cause. All the way through, it's really important to monitor accurately measured height growth, as well as weight growth. And then if there's no other obvious cause, and if growth is slow or falling away from the growth chart, there may be indication to do further workup to see whether that child might have growth hormone deficiency. And really that's where an endocrinologist can come in. What about the G in charge syndrome in terms of the genital development and puberty? So I just want to say here that even though we think about sex hormones kicking in at puberty time, they actually kick in before birth has even occurred. The gonadotropins are the hormones that control the sex hormones in the brain. And even before birth, they're really important for the development, particularly in boys, in terms of the growth of the penis and the descent of the testicles. After that, things tend to be quiescent, and then sex hormones kick in again at puberty, bringing about the changes that we're familiar with. So what happens in charge syndrome, and coming back to that pathway that starts in the brain, people with charge syndrome often don't make enough, if any, of the hormones that control puberty and sex hormone production in the brain. And that results in low levels of sex hormones. There's a really long word that sometimes you may read about. It's called hypogonadotropic hypogonadism. Hypo means low. Gonadotropic refers to the hormones from the brain, the gonadotropins. And hypogonadism just means that the testicles or the ovaries, in other words, the gonads, are not producing enough sex hormones. So in charge syndrome, people with hypogonadotropic hypogonadism may manifest as follows. So at birth, boys may have undescended testicles or a very small or micro penis. At puberty in boys and girls, Puberty may be delayed or absent, or may start but may not progress all the way. And then in adulthood, which we don't really see adults, children's, but there may be infertility. So what can we do about it? We can give back hormones. So in infancy, if the testicles haven't descended and if the penis is very small, we can give back testosterone, which is the male sex hormone, or the controlling hormone, and those may help the penis grow bigger and may also help the testicles to descend. Often the testicles may not descend all the way with hormone treatment, so some children need surgery to bring those testicles down. And then at puberty, we would give back the hormones that aren't typically being made. So in boys, that would be testosterone, and in girls, it would be estrogen, the female sex hormone, and later on progesterone, which is the hormone that brings about menstrual periods. And we try and do this in a way to mimic the natural puberty, so we start with very low doses and go gradually over time. So just back to this paradigm, how can we be proactive, having heard all that in terms of our care for people with charge with endocrine issues? And this is my last slide just to conclude. I want to just emphasize that people who have charge may need to see an endocrinologist all through the lifespan from birth through adulthood. So at birth, baby boys may have a micro or small penis and undescended testicles and may need to see an endocrinologist. Throughout childhood, growth needs to be monitored, and children may need to see an endocrinologist if they're growing poorly or if there are any other concerns for other hormone deficiencies. Around the age of puberty, there needs to be monitoring to see if puberty has kicked in, and if it hasn't, then perhaps treatment needs to be considered to bring about puberty. And then these are some of the issues that can occur in adults. And I think that, addressing, even though endocrinology may seem less urgent than many of the issues that people with charge syndrome may face, I think addressing the endocrine issues is really important in terms of just health and quality of life and psychosocial adjustment. Thank you.
Thank you, Dr. Rutter. So next up, we'll have Dr. Susan Wiley, who's going to give us an overview of when and why you might need to take your child to see a developmental and behavioral pediatrician.
All right, welcome. Glad to be part of this panel. Hoping my slides come soon, but I'll just start talking. We have, as developmental pediatricians, we're basically a pediatric subspecialty. So that means, oh, there was a question. Uh-oh, I didn't know we had a, oh, you guys so I was late to the party. There is a poll, so go ahead and answer that poll, and I guess we'll figure that out in a little bit. So we are basically a pediatric subspecialty. So that means we did general pediatrics and finished all that and could go work as a pediatrician, but decided we'd rather do something else and see kids with developmental disabilities. And so what kind of happens within our field in training is we do learn a lot about a variety of populations, but I would say there's not a lot of training in kids who are deaf, blind in most training programs. And so it kind of often is in the hands of the person in their learning pathway to get more knowledge. And then the other challenge in our field is that there really aren't enough of us. So there's not really enough developmental pediatricians to see all kids with developmental challenges. And so that makes it hard to get into them. And then finally, sometimes programs will do diagnostic evaluations, but not monitoring over time. And we know that kids with charge and other developmental disabilities really do benefit from kind of touch points over time and making sure we're connecting you to resources and supporting growth and development. So one of the things that I like to think about for developmental peds is I think we tend to try to think about things holistically or from a whole child approach. And that gives us kind of something unique maybe compared to some other specialties. I know genetics looks very holistically as well, but sometimes say if you go to pulmonary, they're gonna look at the lungs but you've got the rest of the baby attached or the rest of the child attached. So I think what we do add is a little bit of broader medical understanding. And so I often are thinking about, are there a medical trigger to behaviors, or how is the health issues that have occurred impacting development? And then how do we kind of support that once that those health issues stabilize? Most developmental pediatricians also really think a lot about functional skills, communication skills, and that more long-term view. And hopefully developmental pediatricians also have a good sense of resources, how to navigate systems like early intervention, school programs, transition, medical systems. So even if they don't know a lot about charge, they should know a lot about those sorts of things. So I guess sometimes I'll see kids who've come from the charge or come to Cincinnati for the charge program, and some of them I've already seen a developmental pediatrician, and some of them haven't heard of that. And so sometimes kids are cared for in complex care settings. And so those programs do a lot of thinking about this. But I think what developmental pediatricians add is a little bit more depth and time in talking through these things. And so we also spend a lot of time advocating with you. How do we support needs in schools, write letters, link to resources and things like that. And also, I think what I tend to like to say is making sure we're looking at the donut and not the hole. So a lot of times when people think about kids with charge, it's all the problems that are there rather than the strengths a child has. And so hopefully, if you find a developmental pediatrician, they think like that as well. If you come to a visit with me, I think I do usually do a pretty thorough chart review ahead of time, so I know what health issues and things have occurred, thinking through that health checklist, that what have we missed, and making sure we link you to endocrine and perhaps immunology and genetics. But usually kids have seen genetics as a starting point. But also then, again, kind of really think through that global framework and how do we kind of build the next steps forward. So I think if you find a developmental pediatrician who wants to learn more about charge, that's great. A lot of times I get questions across the country too, just, hey, have you seen this? What would you suggest? So I think it can be a good part of your team. We don't often see kids real frequently, so it's not a every week kind of thing. It's a touch point when it makes sense. So maybe we will have a poll, maybe not. Well, there we go. So 2/3 of you have not seen a developmental pediatrician. And again, there's to some degree that may be related to one, not knowing what one was, and two, the long wait lists in different areas. So you can talk to your pediatrician about whether or not you should see one. And I think we're going to move to genetics.
All right. Thank you, Dr. Wiley. So next up, we've got Dr. Brittany Simpson, who is in our genetics department here, and she's going to give us an overview of when and why you'd be seeing their team.
Yeah. Hi, everyone. As Dr. Hart said, my name is Brittany Simpson, and I'm one of the physicians in the genetics division here. And so we do have a poll. So have you guys seen a geneticist? Got once or twice and regular, or I don't even know what that is. And so I think the poll seems to still work as I
Just
pop
wait.
it up.
It's awkward.
They'll throw it in when they feel like it. It might be
That
mid-sentence. No, it won't be. It won't
Surprise.
So, just to kind of give you guys an overview, I'm sure you guys, given the diagnosis, have heard of a clinical geneticist, but we'll see with our poll. But a clinical geneticist is a medical doctor who takes care of children with rare disease. And so that may be a rare condition. As you guys know, charge is one of those, or that is due to a genetic cause. Whether or not we found that cause, though, is one of the questions. But also we take care of children with rare birth defects or associations like Vactral, or, some conditions your child may have experienced, like a child with TE fistula, things like that. And we also take care of children who may have birth defects or developmental issues due to an exposure while they were in mom's stomach. So, during that important developmental pathway. And so really our role, and we'll go into this a little bit more, is to, again, as Dr. Wiley said, holistic approach and look and see if we can find a unifying diagnosis. What I always tell my families is my job is to learn absolutely as much as I can about your child so that we can take the best care of your child. And so that involves having a diagnosis if we can make one, as well as management and follow-up. Follow-up is very important with genetics. And as well as it's a wonderful time to be in the field because we do have treatments in some cases. And so for charge, what is the role of genetics? So we do, working with Dr. Wiley as well, but performing that general assessment of the clinical picture just to make sure, is this charge, is this not charge? Here in Cincinnati, we are very fortunate to see so many individuals with charge with a very wide range of phenotypes. As Dr. Risma said, that's just the clinical picture that we see related to the genotype, which is that misspelling in the gene, which in charge of CHD7, which I'm sure you guys know. But with that, we see if we do have an accurate diagnosis and look at the whole child to ensure, what known associations they may have, what complications are they at risk for, so that we can screen and prevent. That is a huge part of our job as well. And so in addition to that, part of looking at that whole picture, we'll be looking to see if genetic testing has been performed. I'm very much an advocate of testing the child when we can. Unfortunately, our insurance, I wouldn't call them friends, won't let us sometimes, but we look and see if those have been assessed. And it looks, if we see the misspelling in the CHD7, is that what is likely going on? And although genotype to phenotype, meaning if we know the exact misspelling, can you predict things in the future? In charge, that's not necessarily clear, but we do have those potentials the more we learn. And then also, again, a huge role in follow-up. So, continual touch base with the family and making sure, are all these symptoms due to charge? Are we missing something else? I know charge is rare, but, we do have kids with multiple diagnoses too. So we just want to make sure that we understand what's going on. And so for those who may not be local, because we do see children from around the country here and even some from Canada, but not right now. But anyway, so for those of you who aren't local, just, giving a consultation, even if you have seen a geneticist in the past, but assessing the past medical history to ensure that management is being provided in a accurate way. Luckily here, we have the charge checklist, so making sure those things are done. And then also guiding care. We understand that your child is a child and you have important things for the family, so just making sure that things are being addressed, but in a way that is impactful for your family too. And so the poll, so it looks like most people, as is usually the case, have seen their geneticist once or twice. That is not the model here, which I trained here, so they definitely taught me well. So we are definitely one that believe in regular and established care, just to make sure parents have someone kind of a driver in the boat at times we can be, or just someone you can bounce ideas off, because we do see these children a lot more than other physicians, so we can see if that might be related, might not. Anyway.
Great. Thank you, Dr. Simpson. So I have a couple questions that have come in. So we're just going to stay with you to start, Dr. Simpson. So the first question was, is children being diagnosed with charge who present with many symptoms but may not have the CDH7 gene, do you believe that these children have another mutation that just hasn't been discovered yet?
So that's a great question. So with our genetic testing, we've come a long way, but we're still not perfect. So actually over 90% of kiddos with charge syndrome can have a mutation or that misspelling that causes problems identified. But in those, say 10% max of patients, probably a large portion of those are children where the technology is not there yet. Or, there could be another condition that is like a mimic of charge. And so that's definitely a possibility. So I would recommend, we look for other things. Broad-based testing is available now with whole exome, whole genome, which just means we look at all the recipes to see if we can find any misspellings. And so if that's negative, but the child does meet criteria for charge, I would treat them as if they do have charge. We just either can't find that CHD7 misspelling, or it might be a new gene, but less likely, but we'll see. And that would be great. Yeah.
So one more question for you. Do you believe that children who have the CHD7 mutation, or wait, I'm sorry, I'm misreading it. Do you believe children are at higher risk than others of passing charge onto their children, even if they don't have the CHD7 mutation? So that subset where they're testing negative.
Right.
That's a tricky
Are they
question.
Are they at higher risk?
I would say no, because a child with CHARGE syndrome has a 50% risk of passing on to their children. And so I would very much doubt that they'd have a higher chance. But since we don't know what exactly the cause might be, you could say maybe, but I would say probably not.
Oh, that's great. Can I have a genetics question? Sure. I know. I'm always here to mess it up. You kind of indicated when it's like you're looking for charge and then things that are associated with charge, but things that are not associated with charge. And I think that's a really important concept to kind of maybe expand upon a little bit. What did you mean by that?
So for, CHARGE syndrome is quite complex and it has a huge range. The typical birth defects, would be something that would be, more typical, but we know things like changes to the cerebellum in the back of the brain aren't necessarily in that little acronym, but they're more common. But then if a patient comes in and is having, you're putting me on the spot, like things that might not necessarily be related. So they
Big toenail problem. Let's just make it kind of crazy.
Okay. Big toenail problem. So, if there might be that change that we don't think is necessarily related to charge, although I don't know.
No, I know. I think what I'm saying is
Yeah.
a lot of times sometimes docs will go, oh, if it's not associated with charge, it's not going to happen in you. And so thinking about the child as you have what you have, but you can also have things for other reasons and not just putting everything to the charge.
Absolutely.
And I thought that's what you were meaning.
Yeah, that's what I meant.
Yeah.
Exactly. You said it much better. Thank you, Dr. Riley.
All right, Dr. Wiley, question for you from the audience at home. If we don't have a developmental pediatrician in our area, should we be asking for a referral to see one in Cincinnati?
If you're coming for the charge group, sure. I mean, so what we actually do try to do is even if you didn't know you wanted me, you get me. But I also think you could look regionally. So I don't think you always have to come all the way to Cincinnati. But if there's a program that's a little easier to travel to, most large urban children's hospitals have developmental pediatrics.
But I think it's fair to say that we, as a center, feel pretty strongly that an evaluation by a developmental pediatrician at some point in your child's lifetime would be a good plan.
I think it helps, and I think what happens is you get all into the medical stuff, and then all of a sudden your child's older, and we have all this other stuff, and that if we haven't been proactive, and then also just all of the school supports, behavior issues, things, communication supports, all that stuff. So.
All right, Dr. Ritter, a couple of questions for you. So the first question is do you see a connection in children with CHARGE syndrome and hypoglycemia?
Typically not. However, sometimes children, particularly babies, if they're born with growth hormone deficiency or a deficiency that affects the adrenal glands, can sometimes have hypoglycemia, which is low blood glucose. But this would not be something that we would typically expect to see in somebody who has charge.
Great. And then the next question for you, Dr. Rutter, is why is it important to bring about puberty in those children who have a deficiency of those hormones?
And I get that question asked to me all the time. Why did I send you to endocrine? I don't want puberty to happen. The behaviors are going to get worse. So that's a great question.
It is a great question, and I think many parents are concerned about worsening behaviors. Many parents of daughters might be concerned about, we just don't want to have to deal with periods when they come along as well. I think it's important to replace the puberty hormones. One really important reason, aside from the fact, there's the physical development that may not otherwise occur, but a really important reason is actually for bone health. So we didn't really talk about that much in the talk, but the puberty hormones are really important for laying down of bone in the teenage years and also in early adulthood. And so if there's deficiency of those hormones, people can become osteoporotic, which means that they have fragile or weak bones and may fracture easily.
I have a couple more genetics questions
Okay.
that have come in. So one of the questions is the genetic database that's sort of referenced, is that a worldwide database? And they go on to say the specific mutation that their child has for CHD7 was diagnosed in Europe, and they said that there were no others found in the database.
Oh, okay. So I'm not exactly sure what database they're referring to. I do know, here we have a database for the center that's in development. And as far as the specific change in the database, there have been hundreds of changes. I know one study was like 117, and that was several years ago. And so the most up-to-date things will be a couple of different databases on the internet, I don't know, that I would use to see if the change has been seen before. But that one's kind of hard because there is a website that's the CHD7 website that catalogs mutations, but I'm not really sure how up to date it is. So that's just one of those things where I have a couple different places I go and look every time I get a report.
So it sounds like there's not necessarily one unified
There's
database
not.
across the world.
No, there's not. There should be, though. That would help us out so much if
It
we
would.
could.
It
It
would.
really would.
Yeah.
And that's kind of one of my research interests too that I'm working with the Church Center with. Too.
Terrific. And then I think just a clarification on one of the answers you gave before about children who are diagnosed with CHARGE but don't have a CHD7 mutation.
Mm-hmm.
Do you think it's likely that's just an undiscovered gene mutation? Which I think is what I heard you saying before.
Right. So let me just be a little clearer. So for our genes in our recipes, so the CHD7 gene is really important for development, and it helps turn our genes on and off. And so the way that we test it is we take a child's DNA, we take their instruction manual that we get from their blood, and we literally spell it out. And so the way our technology works is it only spells out what the body is copying when it's using it. But there are other places within that recipe that the body has to use to help copy the gene or copy the recipe. So I like to think of it as a literal recipe. And so what we're really good at copying are the ingredients list, but we're not so great at copying those instructions. But we all know that you cannot really bake a cake if you don't have both, and you aren't very consistent with how you put together the ingredients. And so what I was saying is that the majority of them probably have misspellings in those in the instructions in the bottom of the recipe rather than the ingredients, because we're great at seeing those. But there could be a different recipe completely, but I think that's probably less likely.
All right. Thanks for the clarification.
Yeah, sorry about that, guys.
So I think this one's coming to you here, Dr. Wiley. Are there adult providers who play a similar role as a developmental pediatrician in the pediatric world?
I wish there were. There is no adult counterpart to developmental pediatrics, unlike endocrinology, genetics. Well, genetics kind of spans the lifespan, immunology, pulmonology. There are adult specialty programs for that. Probably the closest thing I've come to is sometimes there are folks who are board certified in both adult medicine and pediatric medicine with an interest in individuals with disabilities, more probably as a medical home. The other people I think about, but we've not really queried this, would be in the field of geriatrics, because in geriatrics, there's a lot of disability that is acquired. And so that skill set is helpful, and yet I'm pretty sure that's not geriatricians aren't ready to take on those next phases. I mean, one of the things that our center does have is a transition program, and we will see kids into their mid 20s to 30s and try to map out, okay, how are you going to land in housing, in employment, in community participation, in healthcare. So kind of thinking, and things like guardianship and financial planning. So we do think about those things in our transition program, but unfortunately there's not a lot of great resources into adulthood.
You're the popular one today. I've got another question for you, Dr. Simpson. So question about the likelihood in a family that has a child with CHARGE syndrome, what's the likelihood of having another child with CHARGE syndrome in that family?
That's a great question. So normally the misspelling happens new to the child. So everyone is unique, and we all have misspellings that our parents actually didn't give us. It's just humans are error prone. It again makes us unique. And so the chances typically are less than 1%, but there can be something called germline mosaicism, which is just a fancy term to mean that that misspelling actually is in the parent's either ovaries or sperm, but they don't know it, and it's just in those cells. And so that has a little higher risk, but we can't always find the change. So if in that case, it would be a 3 to 5% recurrence risk.
So I have a question. Probably all of you could potentially answer, but I think I'll have you start, Dr. Risma. When you see a child who is coming to our center from elsewhere, who has pretty well-established care team at home, how do you view your role as a member of that care team for a child that you may only see once a year or once every few years?
That's a great question. I mean, I think Dr. Wiley summarized it when she said we review a lot of chart. So it's really helpful to have, electronic medical records now that are linked together so that we can very quickly review discharge summaries and things along those lines. It's a lot harder to get information about, how many ear infections per year from an allergist immunologist standpoint, or how many pneumonias a year. So really, we rely on what the families tell us. So it's very helpful for families to be organized in their approach. And some of my charge patients are the most organized families I've ever met. It's really phenomenal because they come with binders, and not just binders, but organized layouts and summaries that I marvel at. And so that is really helpful. It helps you get better care for your child when you go, you have that skill set. Not everybody has that skill set, but it's neat when it happens. So
If any of the rest of you have thoughts on
I
that
think
as well?
to some degree, you have to recognize, am I going to be the one managing this, or am I in a supportive role? And so families really need to know who they're calling for what.
Mm-hmm.
And now we have also kind of health portals, so people might ask questions. Hey, this was the advice. What is your thoughts on that? You've seen a lot of kids. What do you think? So I think it really depends. We have some families who come back at intervals to have care versus every so often check in that their plan is appropriate, and we're doing more of a, you're on the right path, or maybe you could tweak here, you could get that done closer to home versus here.
Yeah, I think, we always support if a family has good endocrine care locally, that's really important. But we can be here as a resource, particularly if families are coming to the charge center. And I always like to think of it really as interdisciplinary care, not just multidisciplinary care, where multidisciplinary might mean that you have specialists in many different fields, but they don't really talk to each other. Whereas I think what we try to do here is offer interdisciplinary care where, we're thinking about, I like your analogy about the donut, but we're thinking about the whole person, not just the endocrine aspects. And so we can talk to each other if there are issues that arise, and there can be that level of communication.
Yeah, I would agree. And, just really kind of, if the patient is from far away, just looking and assessing the whole patient from the genetic standpoint, seeing if there might be any testing that needs to be done, or, if the care is not being managed as, we would suggest. So kind of making recommendations and giving providers locally someone that they could touch base with if they had questions.
Great. Another question that kind of dovetails off of what you all were just talking about is, who's the right professional or the right person to handle and or coordinate with all of the doctors so that the parents aren't falling into that role?
Yeah, it's not perfect anywhere, but I think sometimes there's more of these complex care, primary care homes that seem to try to do a better job of that. It's a really hard role. It's a very hard role for general practitioners because they don't have the resources like care managers, social workers. So it can be hard to find that.
And then I've just got a couple of questions, kind of one back for you. So a diagnosis that was made in a child about 12 years ago in the NICU, and they don't know the specific mutation that was present. Is there a role for retesting to get more information?
So I would say we would need to check. I don't I'd need to check if the child did have the CHD7 sequencing, and that's where I would go first, just to check and see.
Okay.
Yep.
So I was taught by somebody to always go find the data at the origin, site of
Yes.
origin. So they would try to track it down.
We always want the report.
Excellent.
And if you could bring the report with you to clinic, that is
Yep.
so
In the
helpful.
binder.
But in the
So-
binder, but
But it's
if
hard
you
to
as a
find.
family member need a doctor to request it, it's cheaper. So like
Oh,
if you're trying to get your
yes.
own records, you often have to pay. But if we're
Good
requesting
point.
them for you,
Hmm.
we might get it for free. However, it might take us longer.
And then
Good-
Dr.
good
Risma, I
life.
have another question for
Mhm.
you. Do you know the percentage of children with CHARGE syndrome who are diagnosed with SCID or who don't have a thymus?
No, I think that we will, the difficulty of that is that we have newborn screen, and so we now give us about, I don't know, maybe another 5 years, and we'll be able to say, hey, we have 40 or 50 born a year who have SCID across the United States, and of those, 50% are CHARGE. We will be able to give you that information. Like, for example, in Ohio, we went live in 2013. Some of the other bigger states, New York, California, went live, 3 years before that. But the dilemma you're asking is you have to take another level of complexity and ask, what about change the denominator from the entire United States to those who have CHARGE syndrome? And because we're not screening for CHARGE syndrome at birth, I don't have that answer. We screen for SCID at birth. That's part of our newborn screen. But until we start having genetic screens of every infant born, which is going to happen eventually, and Dr. Simpson can speak to that, we won't really have a sense of that denominator.
Great, thanks. And I've got I think we've got time for one last question, which is going to go to you, Dr. Simpson. So if you in a child who has had negative CHD7 testing and nothing that shows up on whole exome sequencing, how do you go about diagnosing CHARGE if they're presenting with symptoms?
Yeah, so great question. So my first question would be, when was it done? Because our technology's better now. And so we, would think about either going to whole genome, which does a better job at reading those instructions and not just the ingredient list. But honestly, if everything's still negative and we cannot find that mutation, I would diagnose them based on the clinical criteria that we know, and there are a couple different ones, I would diagnose based on that and then treat them as if they did, just because we know that, they're at higher risk of things like aspiration. I don't want anyone to miss it just because they don't have that mutation. They're still at risk.
Great. Well, I want to thank all the panelists for your time this afternoon and for both your presentations and answering all the questions. And with that, we will wrap up this session.